Welcome to the First Fill. My name is Katie Meyer, and I serve as the Senior Director of Content Creation here at APHA, and I'll be the host for this episode. This month, we're trying something a little bit different, and we'll release two podcasts. Today, during part two, I'm joined by a geriatric pharmacy specialist, educator, colleague, and a friend of mine, Sean Jeffrey, who will talk a little bit about how he's optimized fall prevention as part of his practice. Welcome, Sean. Why don't you introduce yourself and tell listeners a little bit about your background and experience?
Thank you, Katie. First and foremost, it's great to be here, and thank you so much for the invitation. I guess, my goal for this session is to not trip up too much in sharing recommendations that I think every pharmacist can hopefully feel comfortable making. So as you said, Sean Jeffrey, I'm a geriatric pharmacy specialist with over 20 years of experience in the field. I did my residency training in geriatrics at the Durham VA and Duke Center for Aging, and then spent 15 years as a consultant pharmacist at VA Connecticut, where I was sort of a jack of all trades. I did a little bit of all things geriatrics. This included being part of a home-based primary care team where I saw firsthand the fall dangers in people's homes. I was in the geriatric clinic where we struggled to mitigate fall risk. I worked as part of a geriatric surgery team to prehab or prehabilitate older adults before surgery to help prevent postoperative complications like falls. And I helped stand up our hospital's initial fall screening program. Now, that was my time in the VA. I currently practice within a large employed medical group where I work closely with primary care providers to optimize medication therapy, especially in our older adult population. And I'm particularly passionate about fall prevention, probably because I've lost count of the number of times I've had to pick myself up after tripping over my own feet. But all jokes aside, it's a critical area where pharmacists can make a real difference. And I'm excited to share some insights today.
Thanks, Sean. So today, as Sean mentioned, we're going to talk a little bit about fall prevention, but rather than discuss recent evidence and literature, we'll discuss some strategies and practice pearls that pharmacists can use to identify and intervene to prevent falls in patients that they see that are at risk. So just a little bit of background before we get started. As we've discussed in episode 1, falls are the leading cause of injury among adults aged 65 years and older in the United States and cause an estimated 3 million ED visits, more than 950,000 hospitalizations or transfers to another facility, and approximately 32,000 deaths annually. And these numbers are increasing. One of the major contributors to falls in older adults is increased use of medications, which is where we as pharmacists can help. So this brings me to my first question. Sean, can you tell the listeners a little bit about how the workflow is set up in your practice setting, specifically as it relates to identifying and intervening in patients who are at risk for falls?
Sure. Again, so first things, I'm no longer that pharmacist in the VA. I'm now the director of pharmacy at Hartford Healthcare's Integrated Care Partners. So this is part of our healthcare systems organization that's responsible for value-based contracting, population health, and oversight of our payer-partner relationships, especially in the Medicare Advantage space. So my perspective is maybe a little different here. I work with over 400 primary care providers, thousands of specialists, and we have about 350,000 attributed lives. So that means I'm no longer the individual pharmacist conducting a lot of the one-on-one fall medication reviews. I need to be impacting practices across our state and system. So the question is, how do we do this? It starts with educating our care management team. We have over 50 nurses and social workers where we have an integrated fall risk assessment in their current routine medication reviews. For the members who have perhaps experienced a transition of care, also known as a TOC, or are being followed for complex care management, also known as CCMs. We start by identifying patients who are 65 and older, who are either on multiple medications or are taking any meds associated with a higher risk of falls. So in this case, think benzos, antidepressants, antihypertensives. And once identified, our team does the comprehensive med review, which we affectionately call the fall sweep. The team can then do one of two things. They can either refer back to my pharmacy team for a more detailed fall risk reduction consultation. These are higher acuity, more complicated patients. Or if it's a lower acuity individual, they will make a recommendation to the provider as part of their ongoing chronic care management. And, just like that, we've turned a potential hazard into an opportunity for better care. A second way that we approach this as a system is through the FAM's Age Friendly Health Initiative. And for those who may not be as familiar with what the 4M's stand for, it's a program that began with the American Geriatric Society, and it stands for what matters most. So first thing, mobility, mentation, and medications. So we have a geriatric council that is currently developing training materials for these specific areas that we're going to be disseminating to both clinicians and to patients. And fall risk reduction actually crosses all four of the M's. It really matters to patients because they're deathly afraid of falling. It directly impacts mobility, and mentation is often a key risk factor for falling, and medications drive the risk of or declining mentation and mobility. By focusing at this health system level and raising awareness about the FEMS, by leveraging our care management team, it helps me to be able to extend the fall risk screening and services into our ambulatory providers. On the hospital side, hospitalists do a very good job internally of having those fall risk teams internally to help with all the safety concerns around people falling in the hospital. But the bigger opportunity is certainly in the ambulatory space.
Thanks, Sean, so much for sharing a bit about the really, quite frankly, fascinating work that you're doing and reiterating the importance of 4Ms as well. You mentioned benzodiazepines, antidepressants. So, kind of along that same line, what would you say are some of the most common medication related recommendations or interventions that the team's making to help support fall prevention?
And that's a great question, Katie. And one of our most common recommendations revolve around deprescribing or dose adjustments. So we often suggest tapering off or switching off of benzodiazepines or other sedatives to safer alternatives. That is a big bucket of work, is trying to prevent the ongoing use of benzodiazepines where they don't need to be used. Another big one is addressing polypharmacy. And we know that patients are sometimes on cocktails of antihypertensives that can lead to orthostasis, and that increases their fall risk. We also emphasize on the prevention side, although it's maybe a little bit weaker, the importance of vitamin D supplementation, not just for bone health, but also for the fall risk reduction. And I would be remiss if I didn't say we look for opportunities to reduce anticholinergic burden. I can tell you that trying to pry away somebody's diphenhydramine or their Ativan is sometimes harder than getting a cat out of a tree. So you really do have to have a relationship and a dialogue around getting back to those 4Ms. What matters to that individual?
Yeah, Sean, it's so funny. When I think back to my time practicing as a geriatric clinical pharmacist, patients love their oxybutynin and they love their diphenhydramine. So reinforcing the four M's is obviously very important. But do you have any other tips or tricks that you found when addressing patient or provider hesitancy when they kind of are really hesitant to deprescribe?
Yeah, so convincing somebody to give up that quote miracle cure or their favorite pill can be quite challenging. In this case, what matters most is important for framing the discussion on medications. And any pharmacist can do this. For example, if you have a frail older adult who's using a walker and comes into your pharmacy, take that extra step to review their meds for any potential heavy hitters that can cause falls. Perhaps it's too many hypertensive meds, or maybe they're at your pharmacy counter buying an over the counter sleep aid. This is a target rich opportunity for you to prevent a fall. When I'm doing the fall consults and I have an opportunity to speak to the patient, I will sometimes ask, if you could stop a medication, which one would you stop first? If I were to stop a medication, which one don't you want me to touch? And this line of questioning helps me establish, albeit crudely, the individual's most and least important medications. And from there, I might say, I know this medication helps you sleep, but wouldn't it be great if you could sleep and stay on your feet? I also emphasize the risk benefit ratio, making it clear that the risks may now outweigh the benefits, especially as they age. And with providers, I often highlight evidence from studies that are out there. There's plenty of studies that both highlight the risks and dangers of medications by class or specific medications as causing fall risks. There's the Steady RX study. So I use all of these things to try to back up my recommendations and make sure that they know it's a team's effort. No one's trying to upend their treatment plan, just refine it for the patient's current needs. A little humor doesn't hurt as well. I sometimes joke I'm not trying to rain on anyone's medication parade, but maybe we can dial it back to a drizzle.
There you go, Sean. That's a great way to approach it. Thanks so much for the tips and tricks. All right, let's shift gears a little bit from clinical to billing and compensation because obviously that's very important as well. So, what are some tips or pearls do you have for pharmacists to obtain payment from payers for fall prevention services?
So, billing is certainly everybody's favorite topic right now. And I would say that the key here is really to tie your fall prevention services to existing billable activities. So, for instance, comprehensive medication reviews or CMRs are often covered under Medicare Part D, and you can document fall prevention as part of the CMR process. Additionally, many Medicare Advantage plans offer extra benefits that may cover fall prevention programs. So it's also worth exploring value based care models where improving fall rates can contribute to shared savings. Again, my tip is to make sure that you're documenting everything. If it's not written down, it didn't happen. If it didn't happen, you can't bill for it. So I just want to take a little bit deeper dive into those value based opportunities because I think that this is where we have potentially the greatest future opportunity. It's not fully realized now, but I can tell you in my world where our system has contracts that are what we call downsize risk, where the medical group is at risk for the total cost of care for the members that we're caring for. That really gets people's attention and it allows them to start thinking in creative ways around resources for populations that have outsized risk. And fall prevention is one of those easier things to try to do up front to then prevent somebody from having the sequelae downstream and the costs downstream. So, because you're in a downside risk environment, it allows you to have a greater emphasis on preventive strategies and putting resources where it matters most. So, that could be developing additional education programs for clinic based practices. It could be standing up fall risk reduction clinics because anytime you prevent the ER visit and you prevent the hip replacement, you're saving significant money to the system. And that is going to get people's attention.
Absolutely. That's one of the biggest things. The more hospitalizations we can prevent, the more money that we're saving from a broader perspective. So thanks, Sean, for that perspective. All right. So before we wrap up, just one final question for you today, Sean. What is the biggest advice that you would give listeners that want to take a more active role in fall prevention, but just don't know where to start in terms of implementation, considering their competing priorities?
Yeah, so biggest advice start small, but think big and do, as Yoda would say, right? So don't let inertia keep you from at least doing something. Even if all you do at first is identify one or two high risk patients, perhaps a week, that's progress. Or you could start with maybe an educational campaign. Pick a medication a month and highlight how this medication or class of medications can increase someone's risk of falling. That helps with that conversation to create cognitive dissonance in the mind of the person taking the medication that, hey, maybe there's a concern here, and I have somebody who I can now talk to about this concern. The key is really to integrate the fall prevention into your existing workflow rather than seeing it as an additional task. So you might want to start by adding a fall risk assessment question to your standard medication review if you don't already do that. If you're in a health system where you have access to annual wellness visit data, look for documentation of somebody who's already at a potential fall risk. And once you're comfortable with that, you'll gradually expand your efforts. Remember, every fall you help prevent is one less trip to the ER for your patients and one more reason for them to be grateful for your care. Plus, it's a great way to make a tangible difference without having to reinvent the wheel.
All right. Thank you so much for that, Sean. Let's summarize major takeaways from our time here today. So, falls are a major cause of morbidity and mortality in older adults, and pharmacists like Sean are key in the fight against medication related falls. Some of the key medications to look out for and consider deprescribing to help prevent falls include benzodiazepines and other sedatives, antidepressants, and patients that are on multiple hypertensives. Also, don't forget about vitamin D supplementation. If you come across a patient or provider who's hesitant to make changes, it's important to approach them collaboratively and professionally. And keep in mind the 4 M's and frame the recommendation about the patient's goals and what matters most to them. And lastly, if you're looking to begin more actively intervening for fall prevention, explore tying your interventions to CMRs and value based payment models for reimbursement. And start small, but think big about the impact you're making to patient care. Thanks so much again, John, for joining us today. It's truly been a pleasure to have you. And for folks on the line, if you haven't listened to part one of this month's First Fill podcast yet, that released a week ago. I hosted APHA's Executive Education Fellows, Nick and Yara, and we reviewed the recent USP STF statement relevant to fall prevention and some other evidence based facts. Definitely check it out. For any BCGP credentialed pharmacists, we also recently released a case study on fall prevention in our learning library. Check that out as well to earn 1.5 hours of BCGP recertification credit. And last but not least, don't forget to head over to the Learning Library at learn.pharmacist.com to earn your CE for this month's podcast. We'd love to hear your feedback about how you like the new setup. Thanks and take care.